Hi, everybody. Thanks for being here. It's Friday, January 29th. And by the way, if you take a look at the registration form now, all the old webinars are on there. So if you missed some, you can get to them. You can get to them easily. So they'll be on there forever. Well, maybe not forever, but for long enough that you can take advantage of them. We're gonna have a good session today. You're gonna like this one. I know it kind of sounds all right. Patients got lousy oral hygiene. That's kind of boring. I'm not gonna make this boring. I'm gonna make it exciting. So get your water. We're not drinking up water anyway. So grab some water, and well, don't leave me too long. But grab some water because we all need it. Differences between with somebody your age versus somebody my age is when we drink water, then there's a certain amount of time that's necessary before we need to then dispose of that water, if you will. So anyway, I was going over your patient list. I get this call list every day, okay? Patients who call the office, and that's because I make a doctor phone call. So I call the patient preferably as soon after they call as possible. But these patients called yesterday. I probably won't call them until Monday. But I call them. I say, hi, I'm Dr. Lee Sheldon. Thanks for calling us. Appreciate you making an appointment with us. I understand, and I'll show you what I understand. So I'll give you an example. So Jennifer types these up. So I have the name, and I have the date the patient called, and patient's phone number. And then I have the notes that that were left by that Jennifer made. So it says patient referred by magazine. So we have a magazine that goes out to 5,000 homes every single week. Patient was in a car accident when she was younger, had caps on all her front teeth. About 5 years ago, she went in for a cleaning. Hygienist popped off one of the crowns. The endodontist did a root canal on one on the right side, and 2 crowns were redone. She's been grinding and stressed. Now the 2 crowns that were done 5 years ago have shattered. She spent so much money on her teeth. Her long-term goal is to slowly replace any bad teeth with implants. Patient also has an issue on the lower left side and scheduled on February 8th, and we'll take a sooner appointment if we can give it to her. So it's one. Okay. Second, patient referred by magazine. Patient was told she needs periodontal treatment for the upper, and she has a lower denture. Oh, periodontal treatment for the upper against the lower denture. Whew, I don't know how you wear a lower denture against natural teeth. Okay, so the patient was referred for periodontal treatment because the patient got the magazine, the patient is saying to us, probably wasn't referred to us. Okay, third, patient's boyfriend spoke with Jennifer yesterday, and today she's calling back to schedule. She hasn't been to a dentist since she had 7 teeth extracted about 2 to 3 years ago. Other than consults, which the dentist wouldn't give definitive answers as to what she needed and the cost. She's never been happy with her teeth, would like to be able to smile again, knows she needs a lot of work, so wants breakdown of priority and cost. And by the way, that's what happens. Most of your specialists here, most of your periodontists here, when you market directly to the patient, those are the kinds of patients come in. Very often patients who are frustrated, haven't gotten answers. Patients have been out of dentistry for a long time. So, we get the idea that all of these patients are referred, and if they needed a periodontist, they'd be referred. No, they wouldn't. No, they wouldn't. They wouldn't get to you if they didn't go to the general dentist in the first place, and then the general dentist has to refer to you. First of all, the general dentist has to refer, and then the general dentist has to refer to you. But if a patient goes to the general dentist and the general dentist says, I can do it all, or if the patient goes to the general dentist and the general dentist doesn't have any confidence, how are they going to get to you? And so this idea of waiting for the gatekeeper to send to you isn't necessarily the only way of practicing. You all know that. I mean, those of you who've been around and listened to me for the past 6, 7 years kind of know where we are on that. And you can do it too. People, you'll get just from those 3 different phone calls, when there were 7 people who called for new patient appointments yesterday. 7 yesterday. So they call and they have a lot more needs. And the reason we're doing these treatment planning sessions is to help you fulfill their needs, because a lot of times all we learn is our specialty. And we're trying to go beyond that. So I'm going to give you some different experiences, and that's the reason we're giving different experiences, to allow you to be able to think through a case. It's important. We have another residency program that's signed up this week. For that reason, for the same reason, we need to be able to think through a case. So stay with me. Sometimes it goes slowly, sometimes it goes quickly. And sometimes I'm giving you something that you said, oh, I didn't realize that. And maybe you'll have to hear it 2 or 3 or 4 times before it sinks in. So when I'm selecting these patients each week, it's, yeah, that's a good teaching case. And you want a technique course? I'm not the guy. Want to know how to think through a case? Maybe I'm the guy. Want to know how to communicate it to the patient? Sure. Yeah. So that's the direction we're going. So let's take a look at today's case. Okay. So here we go. Okay, so this was the title, Horrible Oral Hygiene. You already got the title. Otherwise, you wouldn't be coming here, because you all saw the title, so I have to repeat that for you. We thank the Oral Reconstruction Foundation. That's the education arm of BioHorizons for providing the continuing education credit. And as long as you stay on for the bulk of the seminar, you get the CEU for this program. To invite others to the treatment planning sessions, please do. This isn't just for specialists. We want specialists referring to general dentists who are really good, and we want general dentists referring back to specialists. We want that relationship in order to be able to improve patient care. That's what we're looking for. And so if you have general dentists that you want to come onto the program, because we are talking about restorative dentistry here, aren't we? Yeah. Then please invite them to participate. The more, the better. Okay. Hygienists, by all means, they can get CUs too from this program. But for those to invite others, just have them go to directorofdentistry.com, and they'll go onto the home page. You see right at the bottom here. Hang on, I got to get my annotation thing here. There we go. All right. So you're right here. It says it's being hidden by the thing, but you see at the bottom. Please sign up for the free material. Okay. They click on that. They just give their name and email address. There's a place for phone number. You don't need to put your phone number there. And they'll get notifications of this and other things that the IDS offers, but they'll be able to, they'll get a notification directly about the treatment planning sessions every week. Okay. Okay. So here's the patient. So, Amy took the call. This was an internet referral. Okay, so internet advertising works. It works better in some areas than others, but internet advertising works. As long as you have a good homepage and you have a good offer, you're going to be able to get people to call you directly. Okay, good offer. Those of you who've been on with me for a long time know my offer is $79, which includes a CT scan, full examination, 2-hour experience in the office. About 30 minutes of that is mine, sometimes a little bit longer. And usually we get all the treatment planning done in one session, which is our goal. And sometimes we have to go to 2 sessions, depending upon the outside consultations that we need. But 1 session for most patients works a lot better than 2 sessions. So start to gear yourself up towards examining treatment planning all in 1 session. You can do it, okay? Patient said that he went to his ENT and was told there was an infection due to his teeth. His dentist passed away 5 years ago and he hasn't been to the dentist since. He's scheduled on Wednesday, January 13th at 9:40. Okay, made no doctor call. I don't know why, but I didn't make a doctor call. Okay, so these are the assistant notes when the patient comes in. So we've taken the full mouth series of x-rays, we've taken the CT, we've done photos, and the assistant has interviewed the patient. So here are the notes. Patient's last cleaning was 15 years ago. Patient has major recession of the lower anterior teeth. Number 21 is very loose. Patient was diagnosed with periodontal disease before and never kept up with the cleanings. Patient wants to save whatever teeth he can. He's here for a second opinion. I don't know where the first opinion was. Patient went to another dentist and he recommended extracting all the teeth. Oh, okay, that's what it was. So the dentist recommended extracting all the teeth. For those of you who are inclined to save teeth, even if you're going to extract the teeth, if you have the reputation for saving teeth, these are the patients who are going to see you for a second opinion. We do an awful lot of dental implants. So we do. We do. But they see me and they see our office because at least we'll give them a full diagnosis and treatment plan. And if we can save teeth, we will. That's a reputation you develop over a long period of time. That might be in some of your advertising as well, to be able to let a patient know that there is a place you can go where we're just not going to extract all the teeth. That's who you are. Okay, so let's take a look here. And I recorded everything, so hopefully we won't have the glitches we've had the past couple of weeks where we've lost the Zoom and we've had to come back. So let's see if we got it. There's the photographs. Okay, so there he is. What do you think about that? Look at the caries. Now, interesting to see there's more caries on the left side than the right side. Keep that in mind. Okay, not much on the right side. Yeah, plenty of plaque, isn't there? Take a look at that. Yeah. Now, occlusal surface isn't bad, is it? That's not bad on the upper. I guess we missed the lower. There we go. There's the lower right there. Okay, good. All right. So you got the idea. Yeah, there we go. There's the x-rays. So there's a full mouth series. You can see the amount of bone that's lost all over here. You can see that. So let's go through the full mouth x-ray. Sorry about the exposure. You get the idea. The exposure should be better. I know. And believe me, the assistant knows now too. So we go through that. You see the caries, rampant caries throughout, interproximally and on the facial, not on the lingual. On the left side, but not so much on the right side, huh? Not so much. And there's caries in the mesial there. It's a grainy film. Yep. Okay. Might say there's periodontal defect in the distal aspect of tooth number 32. I don't know. Take a look at the periodontal probing chart in a moment. But look, no interproximal caries there. There isn't interproximal caries there. There, sorry, the shadows, but you know, you've got interproximal caries. Yep, you do. Let's go next. So let's take a look now at the CT scan, okay? And we'll go through, you'll see there's quite a bit of bone loss in the teeth. But one thing you want to keep in mind, and how much how much bone support is there for the teeth. You know, it's not just how much is lost, it's how much is there. Despite the worst of circumstances, and hasn't had his teeth cleaned in 15 years. By the way, take a look at the caries. Caries is short of the pulp. It's nice to do a CT scan because you can see the relation of the facial caries to the pulp, can't you? Take a look at that. See? It's short of the pulp, or at least theoretically it's short of the pulp. We know until we prep the tooth, we don't know that for a fact, do we? So we got that. Let's go on the lower, and you'll see some of the same thing. Okay, facial caries, short of the pulp. No toothache. No toothache down there. Okay, that's pretty deep. That's pretty deep right there on tooth number 19. Pretty deep on tooth number 20. Maybe. I don't know how deep it is. It's interproximal. It's kind of difficult to look interproximally on a CT scan. But you got the idea when you took a look at the PAs. Although the PA was kind of blacked out a little bit. It's all right. All right, take a look right there, and look, we're looking at incisal overlap there. That's important. We see the incisal overlap there. That's why we're taking the CT scan in occlusion, always taking the CT scan in occlusion. Somebody asked me what happens with a surgical guide. The lab insists when they make a surgical guide, they need, they can't have the teeth in occlusion. That's fine. Take a second CT scan. It isn't that much radiation. The amount of diagnosis you get by seeing these teeth in contact more than makes up for the radiation, in my opinion. You may have your opinion on this. Well, we take CT scan post-ops after we put implants in, and it isn't that much radiation. But that's your decision. Okay, so now I see the patient for the examination. Patient has allergies, allergy to augmentin, but can take amoxicillin or penicillin. He's taken Z-Pak and steroids successfully. Patient needs and wants. Patient has been out of the dental chair for about 4 years. He was seeing Dr. N. Dr. N has since passed away. Patient said the last time he was there, Dr. N wanted to do a lot of work. The patient said he just did not return. He felt that he was being overtreated. Hear it. He felt he was being overtreated by Dr. N. He said he's been having some health issues recently. He's having some sinus issues, breathing issues. He says when he lies down, he feels like something heavy is on his chest. Well, I'm concerned about that medically, absolutely. And he has trouble breathing, okay? So there's a pulmonary problem, a heart problem, and that has to be looked at. There's no question about that. He also has an irregular heartbeat, takes blood pressure meds. The NT told him to go see a dentist. He felt that the patient may have periodontal disease and infected teeth that may be affecting the sinus. Patient says he only brushes about once or twice a week. It makes his stomach hurt when he brushes and it bleeds. He also has a bad taste in his mouth when he brushes. So we took the CT full mouth x-ray and photos today, and the assistant is saying that patient only wants to be dentally healthy, no cosmetic work. He quit smoking 6 years ago. He now chews sugar-free gum, Mentos, all day long. He did try Nicorette gum, made him sick. He eats a lot of peanuts, says he does not eat or drink much sugar at all. We'll find out in a minute that, in fact, he does eat and drink sugar at all, a lot. And he did, and he still is. But right now, initially, this is what he says. He has a few beers a day. He used to drink orange juice every day. We all know orange juice and the sugar concentration there, almost a gallon every few days. Patient asked if I feel his sick feeling could be coming from his teeth. And I said, I don't know for sure. But I can say there are a lot of infections because I've already looked at these x-rays, bone loss, gum disease, and decay going on. As a matter of fact, I made this comment after I saw the patient for examination so that he may feel better after the teeth are gone. So, all right, so we do blood pressure. It's a little bit high. pH level, we do the pH level on every patient, and particularly in a caries prone individual. Don't you want to know? Don't you want to know what the pH level is? I sure do. If there are a few things that are important in caries. One is sugar, the other is pH. If the patient has a pH of 5.5, the mouth is undergoing continuous demineralization. It's a problem. So that if you're going to try to restore a patient with a chronic pH of 5.5, how successful your restoration is going to be down the line? Probably not so successful unless you're going to reverse the pH in some way. It's kind of difficult. It is kind of difficult. But here he has a pH of 6.5, okay? With a neutral of 7, that's not that far off on a patient who hasn't brushed his teeth. Okay, so that's actually good news for a patient who has this caries experience. All right, so let's go ahead, Angles Class 1, Foraminus on numbers 5 and 6. He has an overbite of 30% and an overjet of 0. Let's discuss overjet, because I've discovered through one of my consultations with a doctor that I work with that there are different definitions of overjet. And I want to show you the definition of overjet that we're working with here. Okay, so here's an example. This isn't this patient, somebody else. Okay, you look at these teeth right here and you look at that and you'd say, well, gee, the overjet may be going from incisal edge to the facial aspect of the lower incisor tooth. So it might be that long, right? That's what you're thinking. And the answer is no, that's not what we're thinking. What we're thinking is if the lower teeth are in contact with any part of the upper tooth, that's no overjet. Okay, why? The only interest we're having, the only interest I have in overjet is functional overjet. When the patient goes anteriorly, when the patient's jaw goes forward. So when the patient's jaw goes forward, are the upper teeth and the lower teeth engaging, and are they disengaging the posterior teeth? If they are, then that overjet is zero. When does a patient have an overjet? Patient has an overjet when the lower teeth are touching air and there's space between the incisal edge of the lower tooth and the cingulum or whatever part of the tooth you're looking at, whatever part of the tooth you're looking at on the upper, the one that would be in contact. If there's a 2 millimeter space between the incisal edge, let's say, of tooth number 24 and the cingulum of tooth number 9, then that distance is the functional overjet. It means when the patient goes anteriorly, the back teeth are still engaging before he finally or she finally reaches the anterior teeth to disengage. Okay, it changes the occlusal scheme entirely. And it also changes the amount of mobility or potential mobility you have, particularly in a patient who's a grinder. Okay, a class 2 division 1 usually has a functional overjet of more than 0. But most of our patients, class 3 case, of course, that's totally different. But most of our patients, the lower teeth engage or almost engage, and we want to know that. And if they don't engage, we want to know that too, because that can be responsible for some of the mobility that somebody's having on the posterior teeth, particularly during parafunction. Okay, if that isn't clear, just question me in the Q&A box, and we'll handle it. We'll handle it later on. Okay, so that's why it's important to take the CT scan in occlusion, because now you can see, without study models, you can see that the lower tooth is engaged with the upper tooth, and there is no functional overjet, so that overjet is 0. Okay. Okay, crossbite is 0, and bruxism, no. Attrition is moderate, abfraction, there's no abfraction, no erosion. TMJ, essentially what I'll do is have the patient open and close his mouth. If I hear a click or a pop, I'll identify it where it is, and whether it's early, late, or mid, and whether it's reciprocal, whether the patient opens and closes. I hear a noise both on opening and closing, and just mark that. Okay, maximum opening is 43, Malampati score of 2. Palatal vault is normal. I covered some of these in previous webinars, so if you have questions about it, put it in the Q&A box, because I've covered all of these previously, and I'm happy to do it again, but just question me on it, okay? And gingiva is inflamed, okay? Calculus is heavy, plaque is heavy. There's a periodontal chart, okay? So you'll see pockets aren't that bad, are they? Really not, okay? I mean, we get some 7s on the lower left side. I got that, 5, 6, 7s, okay? He's got some bone loss. It certainly has some horizontal bone loss at all. It isn't just 5 millimeters of attachment loss, of bone loss. It could be 5 millimeters of attachment loss because there's already horizontal bone loss all over. In fact, it could be more, okay? There's periodontal disease, but take a look at the mobility, okay? 2, make sure, I'm not sure you can see this. Let me make sure you can. Yeah. Okay. So mobility is to here, but 1, 1, 1, 1, 2, 1, 1, 1, 1. Okay. So you've got many of the teeth. And by the way, if there's nothing marked here on these lower teeth, then the mobility is 0. Okay. How do you feel about a mobility of 0 with no caries on the lower right side and some pockets? Do all those teeth need to be extracted? No, you may choose to do it. I'm not saying don't do it, but do they need to be extracted? And if they don't need to be extracted, are you now giving the patient an alternative and having that discussion with the patient? Hey, maybe these teeth can be saved, or some of these teeth can be saved. Patient has no money. Well, wouldn't the patient spend the same amount of money for a lower partial denture as a lower full denture with full extractions? See, let's start to offer something to the patient. Don't give up on a patient just because you've seen the patient one time. And you know now from the title why we're talking about this. I wish I knew which thing to click. Let's see. There we go. All right, so let's take a look at this. And what I want to show you in the anatomage is the evidence of caries. The patient can see this. You can show the difference in the bone levels. You can show how deep the caries is, and the patient can see it. See? That's why this is such a valuable tool. Now, of course, it's valuable for implants too. It is. And let's put some implants in and let's just do something in order to be able to show the patient, hey, I can put these implants in and we can see whether you're a candidate. Oh, the patient said he had no money. Okay. How many people say they have no money? Oh, about everybody who walks in, even people who have money. I don't know if they have no money or not. But if I don't offer them this, do they have the opportunity of seeing something that might be able to be done? Okay, so I'm just arbitrarily putting in 5 implants in the upper, 5 implants in the lower. Arbitrarily, not really arbitrarily. I'm going to do some things in order to be able to make sure the implants are roughly in the right place, but this is not my treatment planning sequence. This is essentially my demonstration sequence. This is what I'm demonstrating to the patient. Showing the patient I'm going to line things up and showing the patient, look at how much bone you have and look at how small the implant is. You've got tons of bone. You could have dental implants placed. Okay, does that mean the patient's going to have dental implants placed? No, patient says I can't afford it. Do an upper denture. That's fine. At least I've given the opportunities for the patient to see what could be done and given the patient an opportunity that patient has never seen before. Am I belaboring this point a little bit? Yeah, probably. But it's going to take a while for us to get all these implants planned. And given the fact that I pre-recorded all of this because I didn't want to have the problem of Zoom shutting off because I overloaded it for doing it this way instead. So all of this I pre-recorded so that Zoom will continue and you guys can continue with me and we can get through this without having that glitch or that break in the middle. Okay, but this is really good. And when I'm saying this is, here's your sinus. We're going to make sure and we already know you have a sinusitis. But there's no sinusitis, not much sinusitis that I can see here from a dental standpoint, so I can rule that out for your ENT. I can rule that out. So essentially, I can show the patient that even if there's plenty of bone for us to place the implant without touching the sinus at all. Don't get wrapped up in sinus lifts. Just because you can do it doesn't mean you have to do it. An angled implant around a sinus works just fine. An angled implant with a custom abutment works really, really, really well, even on a single tooth. Well, if we're going to do multiple teeth, if we're going to do implants all over, then obviously it's no problem at all. So we're going through the lower arch and, is this good bone? It's good bone to me. I'm just lining up. This is exactly what I'm doing in front of the patient. And the patient is watching me do this. The patient's looking at the screen, watching me do this. And the patient is impressed, engaged. I'll point out something like the mental frame in this right here. I'll say, all right, here's the nerve. We have a way of avoiding the nerve, and we'll set up a surgical guide to make sure it's nowhere near the nerve. So let's make sure we get rid of the nerve right now. You can see this implant is right on top. I'm going to move this over a little bit, and that way it's not going to touch the nerve at all. Okay? Because what's he thinking? If he's going to go through treatment, he wants to make sure it's done safely. Well, he's hearing all of that from you or from me while we're doing the treatment planning or while we're doing this setup. Later on, we'll do setup. We have some pretty advanced software to do the setup for our own surgical guides. I'm taking a sip of water now. And then I like to remove the bone because I want to see how the implant's going to line up. You know, sometimes you'll have implants that go really far to the lingual and the upper against the lower, and you're going to have cantilevered forces. You want to be able to predict that in advance. Here, the implants line up pretty well, don't they? Yeah. So here's what I say. We will need to do a set. Well, this is the system writing. We need to do a set of oral hygiene instructions to see how successful we can get. You see what I said? This is what I said to the patient, and the assistant is making the notes of what I say. I'm no longer going to overtreat. He's already said he was getting overtreatment before and decided 5 years ago not to see Dr. N. Besides that, he has oral hygiene problems. He has sugar problems. I'll give you the sugar problems now. You see in a moment. He was using Altoid mints constantly on the left side. Now you know why the caries is on the left side. See, I didn't have to invalidate him. I didn't have to say negative things about him. I didn't have to say you're horrible. I did say we've got to get your act together or nothing that we do is going to work. Nothing. Want to save your teeth? Won't be able to save your teeth. And so we've got to get everything under control. His wife is there with him. Okay. So am I talking to him about treatment? No, the only thing I'm talking to him about is coming back for 3 oral hygiene visits in our office. Just 3 oral hygiene visits. Okay, how much is an oral hygiene visit? $45. Plus he has to buy a Sonicare, an Oral-B, and something like that, and use something between his teeth. 3 $45 visits for us to be able to help him help himself to see if he qualifies for treatment. Is that putting the shoe on the other foot? Have you ever tried that? Now, I'm going to tell you, it doesn't work all the time. It doesn't. But I also don't want to see patients with plaque all over the place. Do you? So we set up 3 $45 visits with the assistant, and we say, let's see if we can get you to the point where we can treat you, because I can't treat you this way. We've got to take care of the sugar problem. Got to take care of the plaque problem. Once we do that, then you want to save the teeth, then we can start talking about saving the teeth, okay? So here's what happened. Okay, so I said that he can, if Rob can take care of his teeth at home, we can try to save the lowers with root planing and fillings and a partial. I said that I can't do that until I can see that Rob is doing his part at home. Patient asked if once a day brushing would be okay. I said, that's fine. Once a day is good enough for me. He's doing twice a week for Pete's sake. Once a day? That's fantastic. Okay. And I said, here's what we want: a Sonicare Oral-B and floss, and that he needs to stop sugar as well, or the teeth are going to continue to rot. And Rob says he will do it. Okay, recommended treatment options right now. Only a set of 2 to 3 oral hygiene instructions and a reevaluation. That's all I committed to. Well, how much is it going to cost of this? How about filling it? I'm not. No. We got to make sure that you can even do this before we can even talk about treatment. Because if you can't do this, then the other guy was right. You got to have all your teeth extracted, because it'll be a waste of money for no matter what you spend. It'll be a waste of money for us to try to save these teeth, because they're just going to rot again. The cause of the decay is still there. If the sugar is still there, if the plaque is still there, teeth are going to decay again. I won't let you spend money with me unless you decide that you can take care of your teeth. Okay? And if you can't, that's fine. That's up to you. Okay? So we set up 3 next visits, and we always will put a next visit in the case notes. If you're not doing that now, do it. Okay? Next visit. So next visit number 1, oral hygiene 1, bring electric toothbrush. Number 2, bring your electric toothbrush. Number 3, oral hygiene visit and a reevaluation with the spouse in the office along with the assistant who's doing the oral hygiene instruction. The one who's doing the examination, it's the same one. Keep that relationship the same. So he has developed a relationship with that assistant. That assistant is doing the examination, the oral hygiene instruction, the reevaluation, and is getting that relationship going. And that's assistant time, that's not doctor time. And let the patient demonstrate how well he can do. Okay, so this is January 5th. This is the examination, and I'm writing the letter. Okay, and we send a letter out, or we'll dictate a letter on every single patient. Why? Because I want the patient to hear me dictating exactly what we said, so he can verify that, in fact, he agrees with what I've said. And number 2, if the patient was referred by an ear, nose, and throat, don't you think I want the ear, nose, and throat person communicated with? Don't I want to communicate with that person by letter to show that I have looked at the patient and that we're treating the patient? Tell me what that does when the ear, nose, and throat person gets a typed letter in the mail, snail mail, not email, snail mail, with my name on it. Do you think that makes a difference? I do. Okay, C. Robert evaluation has multiple areas of caries in both the upper and lower arch. Caries is rampant on the upper left side. After discussion, we've determined that is due to the use of Altoid mints on the left side. However, plaque is abundant, as is bone loss. Caries is significant. There's periodontitis in the molars on both the upper right and upper left sides. They are in close proximity to the sinus. However, sinus membrane thickening is minimal on both the right and left sides. I didn't point that out in the CT scan, but you probably noticed that. And therefore, I don't see, at least at this time of this examination, a direct connection between the periodontitis and the sinusitis, but there could be, okay? Yeah, will I give myself a little bit of an out clause? Sure, I will, but we don't see a cloudy sinus there. So I really don't, do I think there is? No. My opinion, there are not enough reasonably good teeth in the upper arch to maintain them or even to treat them. My recommendation would be extraction of the upper teeth and replacement with a denture for now, and perhaps implants later on. Okay, so I'm going with what the patient wants. The patient says, I've got no money, you know, and he's willing to live with an upper denture. He's got that. And upper dentures are pretty easy to live with, certainly by comparison with the lower denture. I'm not telling you anything you don't know. On the lower arch, there are enough treatable teeth, which may be all of them, that it may be worthwhile keeping those teeth to support a lower partial denture for now. Later on, fixed bridger could be done if we are able to mitigate every causative problem. The causative problems are plaque and they are sugar. If we're able to take care of both of those problems, I think there's a lot of progress that could be made. Now, if the patient had a pH of 5.5 or 5.0, I wouldn't be saying that. Okay, at a pH of 6.5, I am. Got the difference, right? Saying, how do I measure pH? Get pH paper, you know, go on Amazon, get pH paper, and start measuring patients' pH. You'll be doing something different. You'll be doing something new. The patient will say, I never had that done before. That's pretty neat. At this point, my only recommendation will be 3 plaque control lessons. We will use an Oral-B brush and use proxy brushes in the lower arch, and let's see what progress he makes. Once we see what progress he can do and what he feels he can do, well, that's an error in dictation or grammar. Then we will be in a better position to make a recommendation with regard to a treatment plan, and signed by me, carbon copy to the ENT. Okay, so if this we're going to a referring dentist, that's fine. This happened to come indirectly from an ENT via the magazine or the internet. Then okay, I want letters going out to any interested party. I want letters going out to physicians so the physicians know that I'm the guy, okay? You want letters going out to the physicians that are interested in this patient because they want to know that you're the gal or the guy. It's important. There's a PR point. It's even a marketing point. So make sure the letters go out there. It's not enough to just keep internal notes and send an email. You can do that, You can do that, particularly with your regulars, but snail mail sells. People don't get snail mail anymore. It's kind of refreshing to see something that's a typewritten letter, and of course, it's not typewritten. It's generated. You put a stamp on it. Yeah, I know. Direct mail marketing works really well. Notice we send out 5,000 magazines per week. There's a reason we do that. Okay, so sees the assistant for oral hygiene visit number 1. Patient brought in his Oral-B, his floss, peroxide brushes, and his wife. He's done an amazing job cleaning. Now, this assistant is not the best grader in the world. She's pretty tough. There was no plaque to be found. His wife said he's committed to this, and he's doing a great job. He purchased Theramints today. Theramints, well, I'll show you Theramints in a second. He stopped the Altoids. He's not eating the sugar. I'm scheduling him to see me next to go forward with needed treatment. He did see his EMT last week and was put on a Z-Pack for his sinus infection. Okay, so we know that. And by this time, so that's Theramints. Get Theramints just about anywhere now. We can certainly get them online. These are xylitol mints. Most of you are familiar with xylitol. Xylitol reduces the risk of tooth decay. Okay, it's a safe sugar. So, Theramints for Altoids. Good trade? Yeah. All right, so now I see the patient for reevaluation. And now I'm looking at him, and let's get off the screen for a second. Okay, so now I'm looking at him, and Danielle's saying it's really good news. He's very proud of himself. His wife talks about how they've worked together and that they're committed together to reduce the sugar and get things better. He's looking really good. Is there a little bit of plaque? Yeah, but he's looking really good. He's really worked hard. So what's the first thing I'm going to do? Well, first of all, Danielle's already cheerleaded for him. But then, of course, I said, oh, wow, Rob, that's great. You're really doing a good job. Now I think we might be able to do something. Okay. Everybody's on the same page. See, we didn't talk about treatment yet. We only spent $135 for oral hygiene visits. That's all we did. Okay. So good. So let's move on. All right, so I see him and I have the discussion with him. I'm going to give you the gist of the by reading the letter or reading the reevaluation. He's done, Rob is done. Again, I'm dictating this into my phone. It's going into an app, which is then going to be uploaded to the transcription. It's going to be typed. I know it's a pain in the neck. I know it's expensive. It's actually not that expensive. The PR value of something like this is just tremendous. And you pay somebody $15, $20 an hour, whatever it is, in order to be able to type that. It's going to make a difference. Again, you're trying to elevate yourself. Elevate yourself. Elevate yourself by dictating at the chair and letting the patient hear. Rob has done a tremendous job in taking care of his oral hygiene. Say it right into the machine. Wow. Wow. Don't you think he's validated? Now it's going to go to somebody else. It's probably going to go to Dr. ENT. And Dr. ENT says, hey, we got a patient who's willing to put in some effort. And Dr. ENT is going to feel pretty good about it too. A lot of success. He's reducing his sugar as well. Sorry about the spelling of well. He now feels the reason the teeth are decaying on the left side, but not the right side, is that he always keeps Altoid mints on the left side, and that makes a lot of sense. We're now trying to come up with a treatment plan that is going to work. There are two thoughts here. One would be to make an upper immediate denture followed by a permanent upper denture 3 to 6 months later after the tissue is healed. The other would be to retain 4 teeth. So here's the assistant, who's an educated assistant, and says to me, well, is there another way we can do it without extracting all the teeth? And I say, yeah, we could save 4 of the teeth and do root canals on 4 of the teeth and put locator attachments in them. We can put snaps in them. I think the biggest downside risk there is the teeth are prone to decay, and therefore you might spend a lot of money on root canals, $1,000 a piece for the root canals, plus the locator attachments probably cost another $500 or $600 each. for on top of a denture, but we can try it. I'm okay as long as, Rob, you're okay that, if you don't want to do implants, we want to do it this way, as long as we understand the risk. And then he starts questioning me on the risk. And his wife starts questioning me on the risk and wants to know, well, what could happen? I say, well, teeth could decay again. They might not. And the way it would happen would be this. We do the root canals on the teeth. We cut the teeth down. We put snaps in there, and extract the rest of the teeth, and ultimately make something that would snap in. And by the way, I've got a model here. I should have brought the model of this thing. I forgot to do that. Got a model here to show you how a snap denture works. Okay. Well, what happens if it decays? Well, if it decays, he's not going to get a toothache. What's going to happen is the teeth will gradually rot, and finally they'll rot so much that we will, they will take the teeth out. I don't know how long that'll take because I don't know how well we've got this under control. Right now, we've got the sugar really well under control, but I don't know whether the decay will totally take care of itself until after we've treated the decay. So it's possible that we can do the overdenture. In fact, we definitely can do it, but I don't know how it's going to last, how long it's going to last afterwards. I say, he'll keep it for as long as he keeps it. And once it rots out to the point where the snaps come out of the teeth because there's nothing to hold the snaps in anymore, okay, then we'd have to go to a full upper denture, or at that point, we'd have to go to implants, okay? Meanwhile, the assistant is adding up how much it would cost to do this versus how much it would cost to do implants, an implant overdenture. So she knows all the figures. She wants to know what it's going to take. I mean, I give her some ideas with regard to the amount of surgical time that we take, as we talked about last week. We charge in terms of the amount of surgical time that I take. And so each 10-minute unit costs a certain amount. So I let her know how much it would cost this way and how much it would cost with, or what the implant approach would be. And by the way, implant approach is kind of a standard thing. So we've got those fees already down. But overdentures on natural teeth, we don't do that often. So I had to break for a little bit, say, all right, root canal costs $1,000. It costs a certain amount of money to cut the teeth down, and the rest of the teeth are going to come out, and how long it's going to take to do that. And then we go to a temporary denture, we go to a permanent denture, then we put locator dentures in. So I have to go through that. That's fine. And you have an assistant who's good at treatment planning and understands what you say, and you've got your signals down. And we have 3 assistants, and this assistant actually happened to be a 4th assistant who's my office manager, and she used to do this and hasn't done that, but she's doing it now because we're a little bit short-staffed. Okay, so we've all got our signals together. That means the assistant is taking all of the time discussing the different fees, not me, and giving the different options that are available. Okay. So let's continue. Okay, so we're now trying to come up with a treatment plan that's going to work. There are 2 thoughts here. One would be to make an immediate upper denture followed by a permanent upper denture 3 to 6 months later after the tissue is healed. The other would be to retain 4 teeth. And by the way, I never would have said that. It's only because Danielle said it that I said it. I wouldn't have come up with that. But if she asked the question, she's asking the question because the patient may be thinking about that question. Remember, the patient said he wanted to save teeth. So she's asking questions, and all I have to do is be able to answer her questions. Okay? And by the way, I might say, I don't think that can be done, but then I'd have to give her the reason why I don't think it can be done. Because the patient wants to know the reason why. Okay? So understand that you can be fluid in your conversation, and the more elevated the assistant is, the more elevated you are, and the more elevated both of you are in the patient's eyes. And the assistant can take over because she already suggested a treatment plan to me that I hadn't talked about. So, do you think the patient and his wife have confidence in Danielle when Danielle gives the patient the options? Sure. There's lots of time for discussion because an assistant's time is an assistant's time. I can move on to the next patient. Okay, so I'm suggesting number 6, 8, 9, 6, 8, 9, 11. We do the endo on those teeth and cut the teeth gum line, place locator attachments within them, remove the remaining teeth, and you've got the idea. On the lower arch, we would like to retain every tooth except for number 20. That means we're going to do the following. We're going to do root planing on the lower arch. There's heavy calculus, particularly on the lower right side. So let's get that out of the way first. Then let's do the extractions of the upper and tooth number 20. Place a temporary overdenture on the upper arch and a temporary removal partial denture on the lower arch to replace the teeth. Okay. Now I'd make the lower denture without clasps. Why? Because there's caries all over the lower teeth. I haven't even addressed the caries in the lower teeth. All I'm doing is extracting tooth number 20, which I don't think it can be restored. But the caries still remains, but the patient now has an upper denture and a lower partial denture. So now he has some teeth. Temporary as they may be, he has some teeth. Okay, then we get access to the K on the lower left side. And we take care of number 18 DFM with a laser pulp cap. We use the Photono laser, and the Photono laser can provide a pulp cap, a laser pulp cap. In other words, it can coalesce the dentin. So there are patients who may not need endo, and what we're doing is coalescing the dentin and desensitizing the pulp at the same time, and it works pretty neat. It does. Number 17, laser tissue removal with a mesiofacial and a distal-facial mesiolingual and a laser pulp cap, and there's no decay on the lower right side. So there's my treatment plan so far. Once that's completed, then we complete either locator attachments with the natural teeth and a locator attachment upper denture and a new metal-based lower partial denture. Note, we'll be doing a reevaluation before we make impressions of the final dentures to be sure there are no toothaches in the teeth before we reconstruct with a prosthesis. If there are toothaches, then we may have an additional extraction to do, and we say that in front of the patient. After discussing the case, the patient stated that he may do upper solid bite rather than an upper denture. There he is. And he states that he may do upper solid bite. What's upper solid bite? Extractions, implant-supported fixed prosthesis. He had no money. He may be willing to save for that or finance that, because we use a number of different financing companies. Green Sky is the best one. If you're not using Green Sky right now, go to Green Sky, and fill out an application. You'll find you'll get better terms from Green Sky than anybody else. At least that's been our experience. Maybe there are others that are good as Green Sky. Green Sky has been great for us. And that's pretty much it. I hope you learned something out of that. It's a simple case, but there are so many nuances here, and all we did was ask the patient to qualify to do treatment with us. And by elevating yourself through the marketing and public relations that we do, and we teach that in the IDS, then you become the go-to person in your community. And now patients want to qualify for you rather than you selling to them. As soon as they perceive you as the expert, and they do right now, then you can do the same thing. Something you can try there? I hope you can. I've got 3 questions. Let's see what the questions are. Okay, if you're doing overdenture on the endodontically treated teeth, would you have the patient put some gel cam or another fluoride onto the denture each day to keep the teeth calcified? I think that's a great idea. And then the next comment is this would be in addition to regular oral hygiene, and that's absolutely right. Gel cam is a stannous fluoride, or whatever fluoride would be placed into the denture and be allowed to remain there in the place of the position of the tooth knobs. This is the same person. This is Dr. Sandy Halpern, who's a prosthodontist. And thank you, Sandy. Thanks for those hints. And that's absolutely right. You put the gel cam right in the denture and bathe the teeth in stannous fluoride. That's true. Is there another question? Let's see. Thanks, Sandy. He said, I like your Larry King's style, Mike, and Larry King, rest in peace. Fabulous guy. All right, folks, we'll see you again. I'd like you to invite others to, if you think this is worthwhile, will you forward this email? You get the email on Sunday that's a standard thing to sign up. And then you get another one on Thursday. And Thursday, I tell you what the case is going to be. That's why these 2 emails go. Just forward the Sunday link or the Sunday email to whoever you want. more people sign up, the more we improve dentistry, or at least we get a different point of view on how dentistry can be done. And I hope you found that this can help. If you have any comments, email me. Please email me at leahdirectordentistry.com. Good. It's good to see you. I'll see you again next week. Bye-bye.